There we go. All right. Well, welcome. Thank you, everybody, for being here in this wonderful Saturday morning in Milwaukee. And thank you for the privilege of the podium. I really appreciate you guys inviting me here to give a talk. So there's going to be some stuff about what's going on in my lab. But what I want to do here is kind of get a 5,000-foot view and be very future-facing. So let's all get our thinking caps on. So I have some disclosures. My financial biases are here. So I have research funding through these organizations, and most recently NHLBI for my K. I own stock in these companies. Some of them are bullish positions, some of them are bearish positions. So I don't know how you'd make inferences on that. And then my wife also works for Roche. My experiential perspective is that I trained at a very blue collar institution. So we were working at the transition of the 80-hour work week and like having to deal with the transition to an EHR. One of the places that I started at in residence in 2010, like still had paper records. So like literal paper orders. The only thing that was online were labs. And then my intellectual bias is that I'm an adamant believer in patient-centered clinical autonomy. I think that that's probably the most important thing pushing forward as we kind of navigate the role of AI in healthcare. And then finally, my thinking tends to be outcome-oriented, systems-focused, not the strategic level. So those are all the biases, and you know how to take everything I say with which grains of sand now. I'd also like to thank my family for letting me be here. So it means a lot to me that they're able to function without me for a few days. I think this is kind of, in terms of looking at the future, my youngest daughter, Anushri, just had her Annaprashan, which is like a rice eating ceremony where they basically go and eat rice for the first time. And then you set out all these things in front of them that basically they choose their career for like life or whatever. So you can see in the center, there's a stethoscope representing emergency medicine. There was like a pair of loops that's off screen, which she went nowhere near, representing surgery. And then she went straight for the keyboard. And then her mother, who is also EMIM trained from Henry Ford, is like very happy she didn't choose medicine. But I think we can find a way forward to merge these things. So we do have to think that this is going to be a long process. And some of the ideas that we bring here are about making the next generation better, more capable than we were. So these are the goals of the talk. Let's get underway. So basically there's 3 parts of this. Winter's coming, dragons and Valyrian steel, and then on to the future, the prince that was promised. So make no mistake about it. Winter is coming, the AI winter specifically. And we're going to get into what exactly that means. So I want to talk about why the AI hype cycle is special relative to other hype cycles, and also why the AI winter is special relative to other winters in technology. So this is the hype cycle. Just by show of hands, who's sort of vaguely familiar with this? Okay, good. I don't want to spend too much time on things that everybody knows about. So as you know, there's like peak of inflation, and then it comes down to trough of disillusionment, and then we sort of have like steady progress after that. So what's kind of important are like the signs. You know, we have to speak in prophecies. The signs are coming. So these are why I would say we're about to jump into the trough, because we're starting to have a lot of negative press. There's a lot of consolidation among providers, and there's kind of the general thought that maybe everything was initially overhyped. So the question is, how long is this hype cycle going to last? Like, how low is the trough going to go, and how long is it going to take us to sort of incorporating this sort of technology into everyday life? Or is it going to go sort of more or less away like Bitcoin mostly did? So within hype cycles for technology, there's a variety of different ones that we've experienced in healthcare. So these are just to name a few. So let's kind of like systematically approach these. So there's the technology itself. Then we're going to talk about whether or not it requires hospitals' consent to use, patient consent, special end user training, whether or not it's useful only at the group level or could be used by individuals, and then whether or not there's like cost effectiveness at the instance level or only over time, and then like the influence of government regulation. So just by way of example, go through the EHR. So does it require consent to the hospital? Yes. Like private patient EHRs are semi-useless. Does it require the patient consent? Interestingly, no. I would argue that if your patient tells you like, hey, I don't want you putting anything at all in the medical record, you would take paper notes and then store them in a file folder in your desk, that would not be something that they could execute on. Does it require special end user training? Yes. Is it useful only at the group level? Yes. Like the major advantage of EHR is that you can go back in the past and look at prior records from an information search and retrieval standpoint. And then from like distribution of care or whatnot, it's not super useful if you had one patient and like one lab to order. It's when you have multiple tasks and multiple patients that it becomes like useful. And obviously it's regulated by the government, and the cost effectiveness theoretically is driven down over time. If only they adhere to like, FUBU design principles, but it was designed for other people for us. So here we are. In terms of robotic surgery, kind of go through this. That's yes across the boards. Same thing with like endovascular, but AI, I would argue, is different. And the reason for that is it empowers and democratizes both knowledge and action that is independent of regulation by governments and is also independent of adoption by professional guilds. So your patients can go through and look up their symptoms, plug it into AI, see what it comes back. Providers on their own does not necessarily require, like if you get a letter that, your prior authorization was rejected, your hospital doesn't, they may say they have to consent for you to, plug that prior auth letter into GPT and like see what it pops out. But really, they don't have to. There'd be no way of proving that you did that when you're replying back to prior auths. So I would say that's the huge difference between this technology and mostly everything that came before, is that it's literally democratized at the like per instance, per person level, which is totally different. Nobody has a robotic surgery machine in their basement that they use for themselves. So who are we? Getting back to the Game of Thrones analogy. And I would argue that, fortunately or unfortunately, medicine is House Stark. So the major important thing is like, well, which Starks are we? We're clearly House Stark because, at the beginning, we sort of bent the knee to pharma, devices, EHR, hospitals, HMOs, and apparently now it's happening with private equity. So that's my hot take for today. But the picture on the right is basically when the Targaryens, the dragon lords, came through. House Stark was like, well, can't compete with that. We're out. The problem with that is like you can't continuously do that. You need to think in terms of partnerships and potentially new friends. So the real question is, which Stark are we? Are we Ned Stark? Are we Robb? Or are we the hero of the show, Jon Snow? Sort of hero, maybe anti-hero, hard to say. So unfortunately, what happened to Ned, that didn't work out so well for him. He wanted to be outside of the Game of Thrones. He didn't want to be involved in the political intrigue, and he wanted to go back up to his home in the north, and this man got executed. And that, for us, I think, is a telling tale. Like, we cannot opt to not participate in the game. Robb suffered an even worse fate, but we won't get into that right now. So let's say that Game of Thrones is this sort of like very visible hype of all the machinations, the politics, the intrigue that goes with AI. But again, sort of like the show, that is not, in fact, the existential threat that we face. The existential threat is Winter's facing. If you remember for like the book, The Song of Ice and Fire, the show, nobody believed in like winter coming and the White Walkers, so like zombies, essentially for like the first 5 seasons. Everybody was involved in wondering who's going to be the hand of the king and who's stabbing who in the back. But that was never really the existential threat. And for us, it's a similar thing with like the idea of like the AI winter. And it's not necessarily because, if AI doesn't continue to get developed, we're going to have a huge problem. So first, let's be kind of specific about what we mean by an AI winter. So it's like a quiescent period where basically AI development and research doesn't progress as it previously has. To me, it's somewhat unclear if this is like the lack of progress is a leading or a lagging indicator. Perhaps the lack of progress is caused by like lack of interest in funding. So essentially, you don't have enough resources to improve. This might be borne out on a large scale in the sense that like whatever they were doing with AI back like 30 years ago was not going to be possible without good GPUs. It might also be that the lack of funding is caused by a lack of progress, and people only fund things that are successful. So this is essentially a lack of productivity. And then the other question is like, well, was there really a lack of productivity, or was it hyped up and overperceived as a lack of progress when progress was like steadily being made, but nobody recognized it? I mean, life is all about expectation management, not actually about quality management, production management. So this is partially due to destabilizing forces, some of which are internal, some of which are external. So the internal forces are partially things that we do as developers that are, over-promising, the lack of rigorous science. I think in the AI standpoint, the obvious cases of these are things that don't generalize, that it worked really well at your institution, And then there's the reproducibility crisis. You took your model to some other institution, and then you learn things like, oh, it can't actually tell, breast cancer's on mammal. What it can tell is who got a diagnostic versus who got a screening memo. So those are all things that we have control over. So that's why I focus on those as being internal. The other issue is that we may not communicate well the limitations of our model or our system or what have you. Then there are external pressures, which are much harder to deal with, have to be dealt with at the strategic level by institutions. And this is like investor hype or potentially even like critical national reports that we don't necessarily have the ability to deal with, like preventing them from coming out. But we do need to, explain why this is not as big of a problem as it seems, or it's as big a problem as it seems, and here's strategies for mitigation. So, there was the Lighthill report that was released back in, I think it was like the 70s, that basically talked about how AI is essentially overpriced or overhyped. And that's what led to their AI winter then. And we're having a similar sort of signs. There's a recent report from MIT that just came out. Did anybody see this or read this? So this report basically says that like 95% of organizations are not actually getting an ROI despite investing like billions of dollars. They also describe this idea of like the Gen AI divide, which it's not that surprising. Like most technological development is described by power law, and most human systems are. So even in publishing, there's like all these authors that make essentially no money. And then there's like J.K. Rowling that had like similar level of input and is like a multimillionaire because of it. So that's what they describe here, is that the AI divide happens, and that occurs to like both buyers of AI technology who get no value from it unless they're in the 5% that get a lot of value, and also builders of technology. What's kind of interesting, and I think is potentially a little bit innovative in this, is that it wasn't all doom and gloom. They did say that the people who are AI winners basically are developing adaptive technologies that are embedded within the workflows of whatever it is that your industry is doing, and that their systems learn from feedback. So they don't just release something out, make the money up front, and then like not make it better. They use they monitor the performance and feed that back into the system in order to basically make the system better over time. So, I mean, what's the problem with the AI winter? Is it just a problem for, the robots? Like, what about actual humans and patients? Like, why can't we do what we always do when new stuff comes out in medicine, just put our heads in the sand and let it sort of pass us by? Well, like I said before, it's democratized. So it's not like people who are, for instance, slow adopters to, robotic surgery technology. Well, I'll just do it open. I actually had, when I was a gen surg president, one of our older staff that was retiring at one of our community hospitals used to hate laparoscopic because he trained well before that. We did like 50% open conversion for him. So he would, you'd go in, open his sign, he'd stick the port in, and then he would, not even turn on the light sometimes. Be like, it's too hard, let's just do it open. It's like, Dr. B, at least turn on the light and then say it's too hard to do. But I think there's the ability to sort of bury our heads in the sand. Like the same thing sort of happened in endovascular for vascular surgeons, and like people who are old open surgeons ended up basically retiring, and the endovascular train, kind of just kept going. And it's more a distribution of like, well, now other specialties treat a procedure or a condition that we previously treated. But the problem with AI is it's democratized to everybody. So it's between the institution and individual providers, between patients and doctors, between doctors and insurance companies. So you can't just stick your head in the ground on this one. There's also other factors that are causing challenges that are going to be an issue for both providers and patients. So one is that there's a recalibration of expectations. So remember I said life is not really about productivity management, it's about expectation. So some of the challenges that, take for instance, ambient AI technology. So the idea is that, well, you see X number of patients in the clinic. So that's like my clinic. It's like 40 patients in half a day. So I have 20-minute slots, and apparently I'm supposed to see 3 patients in every 20-minute slot with me and a PGY4. So if we have ambient technology that does recording, let's say, you don't have to worry about documentation. Although what you actually need is like the search function to figure out who is this patient and why are they here. It's not so much about the documentation in clinic, because we all just have to wait until the end anyway. But let's assume all that works out well. What the institution might say is like, hey, instead of seeing 40 patients in 3 hours, maybe now you can see 50. What about that? So that's the problem with recalibrating your expectations based on hype. Similarly, at the, kind of institutional level with the O to E ratios, we have a better predictive model that like does this, does that, and the other. Like we're always on the E. We never like actually get off of E and deal with the like actually what's being observed. So usually somebody sets this level of like expectation, and then how it's actually deployed or implemented is the challenge. So for instance, a lot of people in vascular, our DRG is based on, our O to E ratio is based on a particular DRG. So we in vascular division sit there and like hem and haw over like, this one patient death a month or whatnot. And at some point we discovered when we looked deeper into it that what we're actually being responsible for is a full DRG. So every time somebody dies of a PE, we get penalized, but we don't admit patients who have PE. We don't treat patients who have PE. We don't manage them postoperatively. We don't even know that they came in. So that's sort of the challenge of like implementation, is that we have a lot of hype around the technology, and then we say it can do things without necessarily proving it and hold people to that standard. Secondly, in terms of like internal factors, there's obviously, we talked about yesterday, sort of the brain rot, the de-skilling of the workforce, and the like poverty of attention and imagination. So what happens when that occurs like over time? Has anybody here been ransomware before? Oh no? Okay, cool. Well, our hospital had the pleasure of that. So we got the fun of converting to paper records for like, I don't know, several weeks to months. Well, for some reason, they ransomwared a county hospital that is also the busiest dialysis center in the state because of undocumented patients. But I guess they just looked at the picture and like, these guys have money, let's ransomware them. So at the task level, for most of us who train and understand the full process, like that's fairly easy to do, because whether I sit there and bang out my note this way or I like, get hand enough from like writing, like it doesn't really matter. You can do the task. The problem is what happens when you're used to relying on AI for cognition, and now you don't have the ability to gather or interpret that data, because for several generations, keep in mind that in clinical training, a generation, even in general surgery, is like 5 to 7 years, has been going on, and then all of a sudden the ability to do that goes away. So we have to think about those potential consequences to patients and whatnot, and whether or not it goes away because you got ransomware and it's a like instance level problem at your institution, versus whether or not it goes away because they just decided one day that like, oh, this is not HIPAA compliant, or like whatever the rule happens to be, and it essentially gets taken out from under us. Either way, we need to think of strategies where we know how to manage that human system interaction, and then we have a backup plan for what if the system fails, how do you continue the mission? And then the other big sort of threat that's a little bit different now is sort of like the brain drain. So, with a lot of providers developing AI-based technologies, and there's sort of the idea that like some of the best and brightest who are at that intersection can potentially go to other sides of the fence. By and large, when, Intuitive released the robot, there wasn't some large swath of surgeons that went out and did like a robotic startup. So that's not really a threat that we've faced before, but it is something that is a challenge now. I just want to make sure I have until 45, right? Okay, cool. So the next question is like, now that we know winter's coming, we understand the aspects and attributes of the hype cycle, what do we need? Like what tooling do we need to have? Specifically, what tools, processes, strategies, and capabilities do we need to defeat the threat, survive the threat, or even thrive under the threat? So these, I would argue, from the work that we've done in our lab, are kind of strategies that I would prioritize. So one, accepting that humans alone can't do a lot of tasks at scale. There's a lot of shifting demographic patterns, which if you think of it in like a Sun Tzu way is like the battle space or like what terrain you're on. So that's shifting, and it's totally independent of us. We're getting a lot of older patients with more complex disease. There's less providers relative to the patient population. So there's just more, you're going to get at me for this, but like FTEs that need to get done in order to like deliver the same volume and quality of care. But we're not simultaneously dramatically increasing the number of providers, or at least not like physician providers. We've tried it with like APNs and physician extenders, but regardless of who specifically is doing that, there's just not enough overall healthcare providers to manage the increase in numbers and the complexity of disease as we push forward to the future. We also need to start thinking in systems and like new frameworks for like studies, evaluations to figure out, does this work or does this not work? Third, we need to focus on specific context performance and like longitudinal safety that compares it to humans alone. So like every kind of first decision is like, hey, is this better or roughly equivalent to what humans are capable of doing on the order of like accuracy, safety, like those types of metrics. And then lastly, we need to have a mind toward how do we preserve physician and patient autonomy and integrity. So this is sort of like your capital management is essentially like the only vehicle you have to like deal with that. So why can't we rely on humans to do things? In my field, I'm just going to go through like a PAD example. So, human clinicians alone in terms of diagnosing PAD is like pretty challenging. When they do studies looking at, well, how much do like med students and even non-vascular physicians know about PAD, it's like pretty low. It's some combination of reasons. There's like a lack of knowledge about it. Even if they know about it, there might be a lack of skill, for instance, in being able to like personally perform a vascular ultrasound. There might be a lack of inclination and coordinated referral centers, everything. It's like, well, hey, I only treat the left leg. If that's a right leg problem, you got to find a different doctor. And there might be just resources where like in one of our hospitals, for instance, the challenge wasn't we didn't have surgeons. We didn't have a vascular lab. So I can't bring in a patient, like put my magic doctor hands on the carotid and be like, that feels like it's 300 centimeters a second. We need to do something about it. So there's a lot of these factors that go into it. But at the end of the day, the ability to provide the care that we'd want to provide is somewhat constrained if we rely only on like human clinicians. There's also a lack of awareness about PAD that you can't necessarily rely on the patient to like prompt you. There's certain diseases there the patient like provides all the prompting, like getting shot. You don't really need a provider to diagnose that. Most people who get shot, the patient will let you know they've been shot. There's also the fact that like patient-provider communication, which is our primary way of taking a history and physical, which I don't know if they still teach this in med school or who's med students out there? Anyone? Do they still tell you that like 90% of your diagnostic acumen comes from the history and physical? And like only after that do you like go to labs and imaging? Is that a thing anymore? Okay, I'm gonna crawl back in my dinosaur hole then. So these are just kind of various studies that go through and essentially show all the things I've just gotten through talking about. So the clinical interview, which is probably the most important thing, is inherently non-scalable. So this is the structural aspects of communication. So like most patient-provider communication is multi-turn. So you can't even distribute that over like, well, we'll just hire like, more providers. Like your big O complexity of this interaction is the same regardless if you have one provider or 50 providers. Like you need to make the communication itself somehow more efficient. The other issue is like there's basically limited opportunities for one-to-many. Who are my bariatric surgeons out here? Anyone? Okay, well, oh yes, okay, good. So you guys have done an excellent job of figuring out how to offload some of that, at least where I trained at UIC. Like you didn't even get to see the bariatric surgeon until you'd already gone to like the info session and like failed medical management and all of that. So there's limited opportunities that in surgery. It's like basically bariatrics and like transplant. But the other challenge is that if you did have like one doctor and like 10 patients in the room and try to like do a group H&P or something, like you're totally decreasing your like sensitivity and ability to get an in-depth conversation. So for a lot of reasons, like it's not practical to scale that way by just sort of like mass market teaching or counseling or what have you. So if you kind of like look at this at the scenario stage, if you're talking about the bariatric info session, again, like your opportunity for one-to-many is high, but like the depth of communication is pretty low because one, there's not like the in-field expert, like a board-certified bariatric surgeon in those info sessions. And two, if like, you're there with like 10 patients and like one or two of them have like more in-depth questions, even if you could answer them, again, you're like being inefficient. So, and then there's opportunity, or there's situations in which none of that is like even possible. So for instance, like taking a history and physical from a teen, if you're in a kind of challenging situation there, like you need to have very deep level of communication, and it's impossible to do that like in any sort of scalable fashion. So that means that for some tasks, we need to have semi-autonomous diagnosis, so that when we need to have the deeper conversations around, for instance, choice of treatment, that we have time to be able to do that. So to do that at scale, again, we need to think about human-machine hybrid systems and, focusing at the system level. Our lab kind of came up with this like hierarchy. We didn't come up with this, but we more defined it in terms of clinical systems. So think about a clinical socio-technical system. So like at the service level, if you're thinking this is something that could be like a research use or clinical use or legal, logistic, business, what have you, those are composed of certain activities, which are themselves composed of certain tasks. Mostly in medicine, that is some type of thinking task, a doing task, recording or documenting task, and then like communicating it to other providers. And usually for the purposes of like treatment, diagnosis, and selection. So if you think of something like triage, like a classic physician task, that's basically doing diagnosis and prognosis either over multiple patients and then ordering it, or within the same patient, what diseases they have, which one should we treat first. So when you're translating that from a social system to a technical system, those data processing are supported by like pipelines, which themselves may be supported by either agents or models, depending on like whether or not you're doing an agentic framework. So I want to focus kind of on these tasks, as well as talk a little bit about this whole like new agent hype train that's like happening. So we in our lab, which formerly known as IHI, we're actually all going to vote on this in a second, uses what I call the decode framework for developing and deploying AI clinical systems. So this is, if you think about an end-to-end process, you want to define the problem, you want to figure out what data you need and extract that. Then you want to do the compute and optimization, and then you want to deploy it in like real life and see what happens through your evaluation. So these are all at different levels: the data level, the model level, and the implementation level. Right now, our lab is mostly everything before implementation. That's like an R01 problem. So this is a little bit more about like what each area kind of deals with. But the most important thing about this figure is that it feeds back. So every time you do something additional, you need to like feed back. For instance, as going from even defining the problem, you may have a problem that you think is the initial problem, and then you move to like, well, what data do you need to get for that? And you actually can't even answer that problem or that question with that data. And then you need to go back to the drawing board. So everything is recursive as well as iterative. All right, so I wanted to introduce you to like, well, how do we retool so that we can, survive the winter? So part of it is being modular and model agnostic. I think a lot of labs have kind of gone to this already, but we want to develop or have developmental and testing frameworks that are like hot swappable. But I think for most of us in most institutions, the ability to train a foundational model is like unrealistic. Like the number of GPUs we need is just not something that even if all the academic institutions in America banded together, we could ever realistically do. So most of our task is either small model training or fine tuning other people's foundational model. So you want to develop an architecture that is essentially hot swappable. It doesn't matter, you're doing OpenAI, you're doing Llama, you're doing Gemini, DeepSeek, whatever it is, that doesn't really change your fundamental evaluation framework. So for those trainees in the audience, you can see like there's lots of papers you can write from this. You can choose a downstream task. For instance, what is the pre-trained model's knowledge of peripheral arterial disease and ability to make decisions in it, and then compare across that. But the bottom line is your evaluation architecture should be like pretty much hot swappable. So, and the same thing with optimization. What you do to optimize each type of model may depend. And I also want to make the argument here that it's better to focus on open source models and like models that you can run locally. I think that a lot of times we view ourselves as consumers, and when we go to a model that requires like an API call and they're able to change aspects of the model behind the scenes and you don't know what specifically a third party is doing, that's where we get ourselves into a lot of trouble. Because if you deploy this clinically, the challenge is that you have to explain it to the patient. And they don't want to hear that, well, somebody at some company that I don't work for did something different and blah, blah, blah. At the end of the day, that gets coded out as your fault. So I think it's really important that when we're figuring out how to at least go from the 0 to 1 problem, that we make sure that we have the use of open source, open weight models. In terms of evaluating performance, that's like sort of the next obviously big area, but only some aspects of real world performance matter. So we initially used this framework in our lab, the E3 framework. So efficacy, efficiency, and equity. But as we actually got deep on how we're going to do it, but as you know, there's probably not a loud word there. So we have pivoted from that. And now we have a more simplified framework that also will still allow us to be funded. So this framework basically looks at two things in a stepwise order. So the first thing when you're going from a 0 to 1 problem is accuracy. So in terms of your input data, this is a few different elements. So one is like, is the data observable? So like you need to be able to validate or revalidate your ground truth labels. You need to have transparency in the labeling process. Is it consensus? Was the person that said this is, whatever, Hinchy 3, was that person a colorectal surgeon or GI doctor? Or was it like just, whatever college student happened to be working in the lab that week? And you want to have that all recorded so you understand the provenance of this. Without doing this, from a systems level, there's going to be little trust on the part of other providers or patients. And that is the type of thing that leads to the perception of overhype and under delivery. Similarly, if it's deterministic outputs, you want to make sure that you can verify the output so that you're taking away the black boxiness of it, so that you don't have like whatever your downstream clinical task is and you just answer that. You want to be able to verify each of this. So if this person has appendicitis compared to diverticulitis, I want to be able to interrogate the model to know like what side of their body was the pain on and how did you come about that. I want to be able to do studies that allow me to see like what is the model attending to. I want to be able to look at the imaging. If they say, oh, well, it's based on the CT. I don't want to know just the CT's weight was 3.4. I want them to highlight the box around the CT where I can see the appendix, where I can evaluate the colon so that I'm not waiting 10 minutes for the CT to load and scrolling through and comparing through other things. Like that has to be provided in a verifiable format where at the point of care, the end user can verify all the steps that came into like the final output prediction. And then for generative models, I think the most important area here is like whether or not they're providing a decision-focused clinical management like idea. So a generative model, the problem is you can ask it anything. Like that's great, sure. But what you want to focus on in terms of like fine-tuning is like when you ask it things that are not just pontificating about life, but about making a clinical decision, like is that portion of the model fine-tuned? And then let's assume for the sake of argument, you have a model that's like completely accurate, works every time. In terms of adoption, which is as clinicians what we actually care about, we need to make sure the models are aligned. So we've all had that, first year student that comes in and like, tell me about the patient. And then they give you something and every fact that they've given you is completely accurate. But at the end of the day, it just isn't the presentation that you want. Sometimes it's like very obvious and can be dealt with essentially like RLHF or reinforcement learning through human feedback. Like, hey, if you have a ruptured aneurysm in the ED, you need to lead off with, this is operative immediately, as opposed to tell me about the patient's neighbor's dog. And at the end of it being like, by the way, he's coding in the ER. So sometimes it's about moving the formatting around, but at the end of the day, it's context specific. But you need to have the right format of the accurate content at the point of care, and that's what leads to trust in the system and adoption. So let's take a look through, let's see. Let's assume, again, you have your hot swappable model, you're doing compute, and then you're essentially doing some type of optimization. So when you have problems with either accuracy or alignment, there's a few different options that you have. So you can get more data. And I think a lot of our institutions are at this level where the challenge is that your data represents your institutions. I use a little bit different where I am at because we have one of the nation's oldest and largest health information exchanges through the INPC, or the Indiana Network for Patient Care. So we use it clinically. You basically have a portal within Cerner or Epic, and you see most of the other hospitals that are on it. And it's used from a research standpoint as well. I used response to Obamacare. It was like, wait a second. So to win the game, I need the most amount of covered lives. We want to buy all the hospitals. So weirdly, our institution has like sort of rolled into population health. But for many institutions, especially in competitive markets, your real challenge is like you don't really have representative data. The second thing is sort of like, the prompt tuning, and that has to be done at an infrastructural level, because when you deploy these systems in real life, there's no telling the way the user will ask the question. When you were writing your prompts, you ideally thought that you, as a person who understands the sort of computer science behind it, understands the clinical purpose, like you ask the model question a certain way. But you need to go to the least common denominator of like, how would the person ask this information of diverticulitis versus appendicitis at 3 a.m. in the morning when they've been operating all day and they're trying to, just survive the evening? Similarly, there needs to be infrastructure investment in like hyperparameter optimization and stuff like that, because that's something that a lot of times we don't approach in a rigorous way, but for a system that's going to be deployed in real life, you want to make sure, again, that you have the most optimized system that you can. And then again, fine tuning on your particular task. I think a lot of us have played around with these, like, segment anything. And then like, well, if you need to segment a bunch of cat videos or stop signs or whatnot, sure, it's great on that. But segmenting, liver masses, not super great. So there's a step-up approach that our lab has opted to do. So essentially, at the easiest level, you can think about like hyperparameter modification, and then it can get all the way up into like parameter efficient fine-tuning. So this sort of model that I'm showing here is something that you need to think about like at the institutional level and have like standardized way of doing things. And the kind of most important aspect of this is that none of these like step-up approaches is implementable on either the like coding side alone or the clinician side. Like we need to come together in interdisciplinary teams that are high functioning and work well together, because to have all the options to make accurate systems that people are actually going to use, we need to have both sides of this sort of like fence. So again, let's assume that you have like a model that works perfectly. Again, will anybody use it? And part of this is about developing a trust framework. So this is the voting part. All right, so we can't use Chai anymore. There's a fairly famous healthcare organization that deals with AI called Chai, and I was advised that I need to have a new acronym for our lab. So our lab does HealthcareAI, and I'm taking this on the roadshow, and everybody gets to vote. So I'll give you a second to read through choice 1 and choice 2 and let me know. We'll vote in like 15 seconds. All right, we're just going to do it by show of hands. Choice 1, who likes that? Oh, okay, the alchemy. In our lab, we make alchemists. That's good. All right, who likes choice 2? Okay. Alechi. Okay, nobody really likes Alechi. It's the best type of chai. But okay, cool. Well, good to know. This is what pretty much everybody else has voted for. Everybody likes alchemy and making alchemists. So the other big area that I want to talk about is like, how do you get trustworthy systems? So in terms of like getting that stickiness so that people will actually use these systems, there's been a lot of focus on like, oh, we need to have mechanistic interpretability. But I would argue that's part of a full tapestry. So if you look at from the data to model to output to implementation level, there's a lot of other factors that I would consider for a trustworthy system, which is totally different than if the system is trusted. But first, you have to build a trustworthy system, and then you can evaluate providers to see if and when they don't trust the system. But if you don't have a trustworthy system, you can't ever evaluate that, because their answer to everything like, well, why don't you trust what the AI's output for sepsis is? And it's like, basically, that thing sucks. So you first need to have a system that has a lot of these elements, or it's slow, I can't use it, or it gives me a 10 paragraph long output instead of just being like, I think this probability of sepsis is X. So you need to develop all of these before you can actually evaluate trust. And once you work from that level of a trustworthy system, then you can work on the human factors integration so that you can have a high functioning human machine hybrid system. So the other thing that I think we should all focus on in terms of like avoiding the AI winter or the consequences of it is making sure that we're always comparing to expert humans, because that is where we're at right now. And I think this was also mentioned by several speakers last time. So this is a paper that we wrote on using deep learning to identify PAD notes from narrative case records. So broadly speaking, there's two different types of ways to search through notes. There's like keyword search, which is kind of think of it as simplistic levels like control Fing that. And then your challenge is figuring out all the ways somebody might say something about PAD. And this is essentially a rules-based search. And then there's using deep learning, where it takes the embedding of the idea of PAD and searches for things within a like sphere of similarity. So the point here is that deep learning outperforms keyword search across every metric. The challenge that we actually discovered is sometimes the ground truth labels are wrong. So sometimes the model thought something was PAD related versus not. And when we went back and actually validated through like humans reading it, it's like, actually the model is right and whoever coded this was wrong. So for instance, there's a lot of artifact for using billing codes as ground truth. Another one was where it thought that this was not PAD related, but it was coded as PAD. And essentially the language around the operation was about doing like aortohepatic, aortomesenteric, aortorenal bypass. So there's a lot of atherosclerosis and plaque in the area, and that's what was being discussed. So it was found on keyword search, but the model was correctly able to determine that that wasn't actually peripheral arterial disease. So you also want to evaluate the sort of like non-random error through systematic study. It's not super important how you'd implement all of these, but the bottom line is like the three ways you'd want to do it is ablation studies, which are careful and systematic, reverse prediction. So things people care about like, is there a gender bias or racial bias to see if you can take the output and predict people's demographics, and then differential performance. So this gets around the problem of like, well, you don't have enough data. So sometimes you move the data around and test things. Other times you move the model to other people's data. And the question is, like that show, does it drift? Like, does it generalize or does it work in other people's places? So we're working on a few things here. And then in terms of maintaining sustainability, I think it's really important to be broader on our strategy for funding to impact. So with developing new technology, you kind of have two problems that are different boundary conditions. So the first is determining viability. Like, is it accurate? Is it aligned? The second is scale. So this is the difference between a 0 to 1 problem and a 1 to 100 problem. So once you determine that it's like roughly viable, then you need to get money or die trying. Fortunately, I got funded, so I don't have to go seppuku myself. But that's kind of the most important thing is you need to find something that is viable. And then once you have that, you can get funded. And then it's kind of more about capital allocation, deploying things after that. So by way of example, in our lab, I got a K23, which at first we just had a good impact score, but we actually got funded. So after 5 years of hard labor, it's finally sort of starting. But there needs to be an overall plan for how you develop this. I think a lot of times where there's like physician developers in the realm, a lot of things end up as like kind of dead ends. And this is common. But we don't really have the ability to pivot. So if like PAD doesn't work out for me, I'm not going to suddenly discover Whipples because we need to have like clinical technical alignment. So thinking about a plan and sustainable funding strategy is important. So there's like this method kind of going through the NIH pathway where we're going to figure out how to use this for R21s to have front-end capability proven, back-end capability proven. We're going to go to the clinical trial. So that sort of route, and it fits well in solving all of these problems. But the challenge there is like, that's not the only way for funding. And I think broadly speaking, for funding people, because this is all implemented at the person level, we need to think about how do you have new friends? How do you work with industry beyond just pharma and device manufacturers? Like in our state, because Cook Medical happens to be a Bloomington country, like where is the Cook Medical Professor of Vascular Surgery? Like probably should exist. Where is, now that Oracle owns Cerner, the Oracle Professor of Surgical Informatics? Maybe that's some other institution, but seems like that would be something from an institutional engagement level that there should be more of. It's not something that I can do as a lowly assistant professor, but it is something that institutional leadership should think about. Similarly, in rethinking our compensation models, like we need to think about if physicians are going to be useful as consultants outside of medicine. So like think about directly competing with McKinsey. Sometimes those types of consulting firms have they go to, pharmaceutical companies, let's say they want to know about the outcomes of certain medications that they have and whether or not they can find in the data and are they happening in a hidden fashion or not. So if a physician is going to consult with them from the institutional level, the institution needs to figure out how to have that physician's time bought out and have the infrastructure where like their clinics can be covered and all of that. That cannot be dealt with at the individual physician level. That has to be an institutional, like new model of compensation. Similarly, like at the national level, we need to figure out how to be engaged. And for instance, like AI QI labs, like that's something that has gotten very little attention. Now there's sort of like no regulation related to it, but that's something where only physicians can validate because we are the only one, or not physicians, but providers can validate because we know how this applies to patients, whether or not it's like a nursing function, a doctoring function, a PT, OT, what have you. But you need to actually treat patients to be able to understand the potential implications at the system level. And then finally, I think we need to rethink the phenotype of who should be a physician. Like, do 90% of the people in med school really have to be biology, chemistry, or biochem majors? Like maybe there are other opportunities, like maybe more engineers might be useful. And similar with like MD, PhD opportunities, like at our institution, you can't do a PhD in computer science. You have the choice of like anatomy, physiology, like those are the options. And we need to rethink that training pipeline. Like maybe the answer is not even PhDs. Maybe it's double masters, a master's in data science and a master's in something else. Maybe it's no type of master's. It's like, hey, during your research years in general surgery, you spend 1 year getting, doing the research and you spend the next year at Amazon. So I think we need to just rethink these training paradigms. And similarly, with new faculty, we need to think about commercialization potential, not just research potential, because we're thinking how to maintain sustainability over the long haul. And then finally, we got to figure out strategies to upskill the current workforce. If SEAL Team 6 has time to like take off from going and getting Osama bin Laden, we certainly have time to take a step out of the OR to be upskilled. Medicine is the only profession, whether or not you analogize it to sports, there's no sports team in America that only plays games. They have no practices. They just show up to the game, no warm up, just immediately go, go, go. Like that's not a thing. But in medicine, it is. And I think that we need to, at the national level, really think how we would upskill an entire workforce. So thank you very much for your time. And I'd be really happy to take any questions.